Welcome to this week's lecture on Chapter 8, Eating Disorders. I know we're going a little out of order here. It's just the way I wanted to structure the course. So we are jumping back to Chapter 8. I would just kind of want to preface this by saying eating disorders tend to be triggering. Everything that we talk about in here is sensitive, but eating disorders is, I would say, in like the top 3 of triggering subject matter. So just take care of yourself, do what you need to do to protect yourself, reach out if you need support. But eating problems have not always been considered a mental health problem. However, bizarre eating behaviors have been around for many centuries. So there's a lot of documented history of people with abnormal eating behaviors, but they weren't always considered a mental health impairment. Eating disorders were introduced for the first time as a separate group of disorders in the DSM-4 in the 1950s. And I just kind of want to say, for those of you who are not familiar with eating disorders, or maybe just have basic knowledge, eating disorders, there's so much more to them than just the food and the weight stuff. Anyone who has experience with an eating disorder, or maybe you have someone close to you who struggles with an eating disorder, knows that there's so much more to it than food and weight stuff, okay? In fact, food and weight, those aren't really the problems. It's what they're using to treat the problem, just like with substance use. It's not the actual food and the weight or the substance. That's just a symptom of the problem, okay? So these disorders get kind of there's a lot of stereotype and stigma around them, that people just have an eating disorder because they want to be thin, or they think they're fat. Again, just a symptom, not the problem. They are very serious and can be fatal. Eating disorders come on in an insidious way, and we began seeing an increase in eating disorders in the 50s and 60s. The major types of DSM-5 eating disorders include bulimia nervosa and anorexia nervosa. Bulimia is out of control eating episodes, which are known as binges. And then they're followed by some type of compensatory behavior, meaning some way to try to get rid of the calories consumed. And that could be self-induced vomiting, excessive use of laxatives, or other attempts to purge up the calories consumed. Anorexia is the person eats only minimal amounts of food or exercises vigorously, so that the body drops down to a dangerous weight, low weight. And then we have binge eating disorder. We're going to talk about that in a minute. This is a new diagnosis, actually, and I'm mentioning it here, but don't freak out. There's going to be a whole slide on it. And that's binge eating disorder is the same thing as bulimia minus the purging behaviors. So individuals may binge repeatedly and find it distressing, but they don't attempt to purge the food. So there are, with all types of eating disorders, there is a severe disruption in eating behaviors. We sometimes refer to this as disordered eating. Weight and shape have disproportionate influences on self-concept. So all of us, to a certain extent, care about the way we look. Most of us want to be healthy, in shape. Some of us place more of an emphasis on it than others. It's just kind of about our values, and it comes on a spectrum. Someone with an eating disorder, it's just exacerbated. The chief characteristic of these disorders is an overwhelming, all-encompassing drive to be thin. Often people with anorexia who are followed over a sufficient period, we see that up to 20% die as a result of their disorder, with slightly more than 5% dying within 10 years. Anorexia is one that is really drawn out. It's not a quick fix. It's a tough one to beat. In fact, anorexia has the highest mortality rate of any psychological disorder reviewed in this class, including depression. I'm going to say that again. Anorexia has the highest mortality rate of all psychological disorders, including depression. And that is not only because there's a physical component here. So yes, they don't take care of their bodies and they die because of physical complications, or it's because there's a high comorbidity of depression and suicidality here, okay? From 20 to 30% of anorexia are deaths related to suicides, which is 50 times higher than the risk of death from suicide in the general population. Suicide attempts are very common among people with eating disorders. And with all eating disorders, there's an extreme fear and apprehension about gaining weight, okay? Any type of weight, even if it's like a subset of a pound. So an overview of eating disorders, and even though there are different types of eating disorders, they all kind of have a lot in common. There is strong social cultural origins driven by our Western emphasis on being thin. So there's a cultural component here. A growing number of studies in different countries indicate that eating disorders are widespread and increased dramatically in Western cultures from about 1960 to 1995, particularly bulimia. What is peculiar about these disorders and what kind of separates them from other disorders in the DSM is that they are widely linked to Western cultures where food is, not lacking and physical appearance is highly valued. Unlike most disorders of childhood and adolescence, eating disorders seem to be disproportionately related to social cultural influences rather than psychological and biological influences. But that doesn't mean that's all of what it is, okay? But we can't lie here, and we can't avoid the fact that our culture does value thinness. And if you compare actors and actresses back into the 50s, 60s, and 70s compared to now, they get thinner and thinner. And, so back in the day, Miss America, the average BMI was 22, and that was considered a normal range. That's considered a normal range. Now it's down to 16.5. So our expectations are getting unhealthier and unhealthier. So like I stated, DSM-5 introduced a new form of eating disorder, and that's binge eating disorder. And this involves disordered eating behavior, such as consuming a large amount of food in one sitting, thousands of calories in a small window of time, which is considered a binge. And it may involve fewer cognitive distortions about weight and shape than we see with bulimia and anorexia. So there's a less preoccupation with weight and shape. Although they aren't confident in their size and their behaviors are distressing, there's less of a focus on being thin when someone's fighting binge eating disorder, okay? So obesity. Obesity is considered a symptom of some eating disorders, but not a disorder in of itself, okay? So being obese does not mean that someone has an eating disorder. They can, but that's not like a DSM diagnosis. It's important to talk about, though, because it's thought to be one of the most dangerous epidemics confronting public health authorities around the world today. Rates are increasing. 70% of US adults are overweight, 35% are obese. Childhood obesity is a chronic medical condition. And there's a big mental health component that comes with it as well. Usually if someone's obese, there's something that they're trying to compensate for, can cause to overeat and exacerbate their symptoms as well. A lot, serious health risks come with obesity, including cardiovascular strain, increased risk of premature death. And obesity is determined by the BMI. Definitions of what it means to be underweight, overweight, and obese will be discussed further later, but they are based on the body mass index, which is highly correlated to the amount of body fat that we have. Okay, so this slide is actually what the BMI looks like. But I want you to know, so you probably have seen this in your doctor's office. Basically what you do is you take your height and then you go where your weight is. And then it'll give you a number, and wherever you fall, underweight, healthy, overweight, or obese, extremely obese. But I want to point out here that I don't like the BMI personally. It's not always a good indicator of health. This is because it's insensitive to body composition. Someone whose weight is largely muscle is likely to be healthier than someone whose weight is largely fat. So, for example, football players, they're in incredible shape and they have a lot of muscle, but they often fall within the extremely obese or obese categories because muscle weighs more than fat. So it's not always a good indicator. There's a lot of errors. So just kind of be cautious with that, okay? We have to take into other things into other consideration here. But let's start with bulimia. Okay, so much more common than anorexia and a lot less obvious is bulimia. In fact, many of us may know someone who has engaged in binging and purging. It's more common than we think. And it's one of the most common psychological disorders on college campuses. So binge eating is the hallmark of bulimia nervosa and binge eating disorder. So what classifies a binge is a large amount of food, typically more junk food. So it's not, someone's not really going to binge on like fruits and vegetables, but they're eating a lot of carbs, sugar. The amount of calories consumed varies from person to person, but usually it's thousands of calories in one sitting. So the person eats an excess amount of food in a discrete period of time. So it's not drawn out, it's super rapid, and they're hardly breathing. It's kind of like maybe they're not even enjoying the food and they're just missing body cues of feeling satiated. They go beyond feeling full. The binges usually have a perceived sense of being out of control. So just as important as the amount of food eaten is that the eating experience is out of control. So they feel like they don't have control of themselves during these binge episodes. They can't stop eating. And this next one's really big. There's a lot of guilt, shame, and regret, almost always. There's this feeling of disgust afterwards. And they do a lot of it or most of it in hiding, so no one else could see them, which tells us that there's a lot of shame. So there's the secrecy component. So maybe they'll go and do it in their car. Maybe they'll do it in the middle of the night when no one's home. So that, which brings us to the next point, is that they may hide their behaviors from family and friends. It's not uncommon for family members or partners to not know about, that someone's bulimic. I've had several clients. I just got a referral actually for a teenage girl, and her mom, I was talking to her mom, and basically her mom, the way she found out that her daughter was bulimic was that her daughter was binging and purging in her room, and she was using like containers to throw up in, and she found all these containers, which I know is disturbing to hear, but I just kind of wanted to show you that it's usually done in secrecy before they're found out. And like I said, foods consumed are usually high in sugar, fat, or carbohydrates. So it's cookies, cake, chips, fast food. And then because of all the shame and guilt and feelings of, oh my gosh, what did I just do? It just exacerbates the stress and the cycle. You'll see there's a lot of like parallels to addictive behaviors with eating disorders. So then following a binge is any type of compensatory behavior, and it's really, these behaviors are designed to kind of make up for the binge or kind of reverse it as best as they can. It's attempts to compensate for the binge eating and potential weight gain. But in reality, the digestion process begins as soon as someone puts something in their mouth. So as soon as we put a piece of a food in our mouth, our body starts to break it down. So no matter how much someone throws up or utilizes laxatives or exercises, the most we could get rid of is 50% of the calories consumed, okay? If that. The longer one waits, the less likely they'll be able to get rid of most of the food. And so what ends up happening, because even if you throw up as much as you could throw up or exercise until you're, really, really, really just exhausted, only 50% of the calories will be, if that again, will be burned off or get, gotten rid of. And what ends up happening is weight gain. So someone with bulimia nervosa, it's much less obvious than like a binge eating disorder or anorexia, because they're usually of normal weight or a little bit overweight. The most common purging method is self-induced vomiting, but purging could also include the use of diuretics or laxatives. Some people use both methods or more than one, so it's not uncommon for someone to do self-induced vomiting and also use laxatives. Excessive exercise. But excessive exercise, that's a behavior that's more commonly seen in anorexia. And then after the binge and the purge, usually becomes a cycle of fasting or food restriction. Going on a binge, then heavily restricting their caloric intake. And because this is what happens, is that they are really ashamed of their behavior and they have these feelings of disgust, and they're like, okay, I'm never going to do that again. So I'm going to go on a diet, restrict my calories. Restricting is never good because it leads to a feeling of deprivation, being deprived, and that usually goes into inducing another binge. So because they feel deprived, they haven't eaten, they may eat one cookie and then just feel like, okay, I already screwed it up. I'm just going to eat this whole pack of cookies, and then it drives and induces another binge. The cycle repeats, okay? That's why diets don't usually work. Diets that cause a lot of restriction, because deprivation leads to binging. So the diagnostic criteria for bulimia nervosa, of course, we have these recurrent episodes of binge eating. So, everyone overeats sometimes. It's called Thanksgiving, right? I'm guilty of it too, but those are like social occasions. And so someone with bulimia nervosa, the binging's continuously. And then there's the use of the inappropriate compensatory behavior in order to prevent weight gain. So again, laxatives, diuretics, self-induced enemas. The binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. And then the self-evaluation is unduly influenced by body shape and weight. So basically their self-worth comes from the way they look. There's a big emphasis on shape and size. The disturbance does not occur exclusively during anorexia. And you'll see this later, okay? Because some, within anorexia, some anorexics also binge and purge, but there's a subtype for that. So bulimia nervosa is different than anorexia binge purge type, okay? And that is really determined by their dominant behaviors as well as their BMI. So we have 2 different subtypes for bulimia nervosa. The first is the purging type, and this type of bulimia nervosa accounts for the majority of cases of those suffering from this type of eating disorder. With the purging type, individuals will regularly engage in self-induced vomiting or abuse laxatives, diuretics, or enemas after a period of binging. The non-purging type is when the individual uses other inappropriate methods of compensation for binge eating, such as excessive exercising or fasting. In these cases, the typical forms of purging, such as self-induced vomiting, are not regularly utilized. So someone with bulimia nervosa purging type, they engage in self-induced vomiting or abuse of laxatives, diuretics, or enemas. The non-purging type is someone trying to compensate in a different way, such as exercising or heavy fasting afterwards. This is just kind of the typical bulimia binge purge cycle. So the person has these tensions and cravings, okay? So there's like life stressors, maybe trauma history, leads them to a binge. And then they're like, oh shoot, what did I do? I can't gain weight. So they engage in some type of purging to try to avoid weight gain. And this whole cycle right here leads to a bunch of shame and disgust beyond what they already had. The reason why they're already engaging in binging and purging is because they already have a lot of shame and disgust of themselves. And this just exacerbates it. They're like, oh my gosh, that's it. I'm never going to do this again. I'm going on a diet. They stop eating. They feel deprived. This leads to tensions and cravings. And then they binge again, and the cycle just repeats itself, okay? So there's a lot of medical features, unfortunately, that come with eating disorders. This is kind of what makes eating disorders unique from other mental health components, is that there's a huge medical piece as well. As you can imagine, the constant cycle of binging and purging is really hard on someone's body. Like I told you, most of them are within 10% of their normal body weight. So they're either maybe slightly underweight in average weight or slightly overweight, okay? But purging methods, any type of purging, self-induced purging, can result in severe medical problems. The most typical that we see is erosion of dental enamel electrolyte imbalances. So let's start with the dental enamel piece. Sometimes the dentists are the first to notice. So they might say, it's a teenager, they notice that their teeth are really damaged from all the acid from purging, and they bring this to the parents' awareness. Electrolytes I want you to know that electrolyte imbalance is the most common and serious medical condition that comes with bulimia nervosa, is the electrolyte balance. Okay, so I want you to know that because they're likely dehydrated from all the purging. Kidney failure and cardiac arrhythmia, which just means irregular heartbeats, seizures, intestinal problems, premature and permanent colon damage from all the repeated vomiting. They also have, you'll notice with someone with bulimia nervosa that they look kind of like puffy, and that's because the salivary glands are enlarged because of the induced vomiting. Some individuals with bulimia nervosa may have calluses on their fingers or the backs of their hands because of caused by the frictions of contact with the teeth and throat when repeatedly sticking their fingers down their throat in order to stimulate the gag reflex. Surprisingly and kind of paradoxically, young women with bulimia nervosa develop more body fat than the average age and weight matched healthy controls. Like I said, that's a paradox because it's what they're trying to avoid, okay? But with all of this said, a normalization of eating habits can quickly reverse these imbalances. Some things might be permanent if it goes on too long, but if we stop it, then we can reverse the damage, okay? So associated psychological features. So along with the medical components, of course, we have the psychological aspects, or else it wouldn't be considered a psychiatric illness. An individual with bulimia usually presents with additional psychological disorders. So comorbidity is what we're talking about. And this is particularly mood and anxiety disorders. Most are overly concerned with body shape. There's a huge, huge, huge fear of gaining weight. Like I said, I'm going to say it again because it's so paradoxical. Surprisingly, young women with bulimia also develop more body fat than age and weight matched healthy controls. And that's because of the types of food that they are consuming. And then when they're constantly purging, they are messing with their metabolism. Most have comorbid psychological disorders. Like I said, 20% meet criteria for a mood disorder, 50 to 70% have met criteria for a mood disorder at some point, even if they're not currently meeting it. For a number of years, one prominent theory actually suggested that eating disorders are simply a way of expressing depression. However, most evidence indicates that depression actually follows bulimia and may be a reaction to it. So it just kind of depends on the person. 80% have met criteria for an anxiety disorder at some point. Patients with anxiety disorders don't necessarily have elevated risks for eating disorders. However, usually the anxiety follows the bulimia. And then nearly 2 in 5 people also abuse substances. More so, substance use is more common among bulimia nervosa individuals than anorexia. It's bulimia nervosa is strongly related to anxiety disorders and somewhat less to mood and substance use disorders. There's a lot of emotional instability with those who are struggling with bulimia. There's a really interesting story about Lady Gaga and her experiences with eating disorders. That's on page 70 or 277. I encourage you to read it. Okay, let's jump into anorexia. So anorexia nervosa literally means nervous loss of appetite. However, that is strongly misleading. I don't know why they call it anorexia nervosa, because these individuals do not lose their appetites. In fact, they are always thinking of food. They are always hungry. They just, part of the hallmark feature is the control and not wanting to consume calories. So the hallmark of anorexia is extreme weight loss, which is why we could see it, why it's more visible than bulimia. In anorexia, the individual is severely underweight, which would not be the case for someone with bulimia. People with bulimia, like I said, you usually can't see it because they're within average range or even a little above. In anorexia, the restriction of calorie intake below energy requirements is constantly occurring, so sometimes defined as 15% below expected weight. So when they're underweight, that's not healthy, even though our culture values thinness. Just because someone's thin doesn't mean that they're healthy, okay? It threatens someone with anorexia, their life's in danger. And they have this intense fear of gaining weight. Both anorexia and bulimia are characterized by a morbid fear of gaining weight and losing control over eating. So with anorexia, there's this huge fear that if I eat, then I'm going to lose control, and then I'm going to gain weight, and then I'm just going to keep gaining weight. People with anorexia, a big distinction between anorexia and bulimia is that people with anorexia are not ashamed of the disorder. They're in fact proud of both their diets and ability to control what they're eating and their weight loss, whereas people with bulimia disorder have a lot of shame. So anorexia is not, you don't just wake up one day and say, I'm going to be anorexic. It's very insidious, okay? It often begins with dieting. No one wakes up again and says that I'm going to put my life in danger and be anorexia. So like I said, the term's really misleading. These individuals usually they're not averse to food. They become very interested because they're starved. They start to obsess over food and they become interested in cooking. Maybe they become chefs preparing food for a bunch of people, their family, but they're not eating it themselves. And there's also, that may be a way to also hide their disorder, but it's also an obsession too. And they often hoard food. So we have different subtypes, just like bulimia. We have the restricting type, and this is kind of the most common, the diet where they limit calorie intake and there's no form of compensatory behaviors other than maybe exercise, but that's not usually because of a binge. But then we also have the binge eating purging type. So even though they're not binging, or their binges are much less significant, frequent, and large as someone with bulimia, maybe start to purge after anything that they eat. Okay. So even though they're not actually binging, anytime they eat anything, they're purging. Okay. Approximately half the individuals who meet criteria for anorexia engage in binge eating and purging. Anorexia is much less common than bulimia, but there's much overlap and crossover between the two. So a lot of times someone will start out anorexic and then they'll cross over into bulimia territory. And that's a lot of times due to the deprivation, okay? Many people with bulimia also have a history of anorexia. Restriction of energy intake relative to requirements, leading to significant low body weight. So although decreased body weight is the most notable feature of anorexia, it is not the core of the disorder. Many people lose weight because of a medical condition, or just going on diets. But what makes this different is that there's this intense fear of gaining weight or becoming fat. So there's this constant fear of, even if it's not scientifically possible, that I'm gaining weight. So they engage in a lot of checking behaviors, weighing themselves multiple times a day, body checking, measuring their arms. So it's this just extreme fear. There's a disturbance in the way one's body weight or shape is experienced. So oftentimes their perception of themselves is off. They don't view themselves as other people. So they might have this really emaciated appearance or prepubescent body type, but for them, they don't see it that way. The most common cycle of anorexia begins in adolescence when maybe the child's slightly overweight or they go through puberty and their body changes. Maybe they become a little more curvy, which is completely normal. And then they don't like it. They start to diet and it escalates into an obsessive preoccupation with being thin. And it just kind of spirals from there. Okay. So like I said, the subtypes are there. We talked about those. Defining features of anorexia nervosa. Most show marked disturbance in body image. Individuals with anorexia are never satisfied with their weight loss. Staying the same weight from one day to the next or gaining any type of weight, even though we know fluctuation is common, is likely to cause intense panic, anxiety, and depression. Only continued weight loss every day is considered satisfactory in their eyes. So even if they're up just half a pound, or even if they just stay the same, that's seen as failure, okay, or threatening. Just like bulimia, most have a comorbid psychological disorder. 70% have depression. There's higher than average rates of substance abuse and OCD because OCD, there's a lot of rigidity within this disorder, and any type of OCD behavior gives them a sense of control. In anorexia, unpleasant thoughts are focused on gaining weight, and individuals engage in a variety of behaviors to try to manage that anxiety. So I'm so scared of gaining weight, so I'm going to, overly exercise, do, 404 jumping jacks every 30 minutes or something like that. So it's like these compulsions about exercise, and that's tried to manage their fear of gaining weight. So there are a lot of parallels to OCD behaviors. Starving. So what happens is when our bodies are not receiving adequate nutrition, our bodies become starved and it starts to borrow energy from internal organs, leading to organ damage, including cardiac damage, and that could lead to a heart attack. Okay. So lots and lots of medical conditions with anorexia. The first is amenorrhea. And this is when a girl loses her menstrual cycle due to low body weight. And a lot of a lot of individuals with anorexia, when they stop having a period, for them that's a good thing. They're like, okay, like that is in their eyes, even though that's a huge red flag that they're not healthy, in their eyes, it's like a success. Okay. And it's a huge thing not to have a period, because when we don't have periods, our bodies aren't absorbing calcium properly, and it leads to osteoporosis and a number of other things. Sometimes women will say their medical team is on their back, like they've been in treatment. Sometimes they will have an artificial period, like they'll start taking birth control, but that's not the same thing. Okay. They have dry skin because they're not getting enough oil, and that also comes with brittle hair and nails because just the lack of nutrition. Very, very sensitive to cold temps because of the low body fat. Lanugo is interesting because their body fat is so low and they're so sensitive to cold. Someone who's extremely underweight, their bodies will start to grow like this fine layer of hair on their limbs or their cheeks or their stomachs, literally their body trying to keep itself warm. Okay, that's how bad it is. Cardiovascular problem, electrolyte imbalance, and like I said, most deadly mental health disorder due to organ damage. Okay, so this is a tricky one to beat, and there's a huge medical and liability component, which is why a lot of therapists shy away from treating eating disorders. It's a specialty. You have to have a whole separate training for eating disorders because their lives are in danger. I wanted to point out, this is a huge trigger warning and very, very scary. So there are a number of pro-eating disorder websites. They're called pro-ana, like pro-anorexia, or pro-mia, like pro-bulimia. And basically, it's these websites promoting anorexia and bulimia, how to be a better anorexic, how to be a bulimic, how to fool people. So there are literally tips about, so say someone like a minor's being forced to go to treatment, they have all these tips on how to make themselves weigh more. So like they get really good at fooling people. So I'm going to fool them to make them think that I'm getting better, but really I just am wearing weights on my body, so I am weighing heavier, or I'm drinking a ton of water right before I weigh, so my weight comes bigger, or more acceptable. You see things such as nothing tastes as good as skinny feels. You'll never get skinny if you keep eating. The pro-ana community has helped me avoid going to the doctors, or if I have to go, shows me tips and tricks to make myself seem to be a normal weight when I go to the doctor. So you want to be anorexic? If the answer is yes, then good for you. Now it just goes to show that you have a lot of control over yourself and what you eat. But before you get started with this lifestyle, let me warn you, once you start, there's no going back. If you ever do go into recovery, then you'll only be fat again, and we will soon come back. So are you ready to change your life forever? So again, this is not a choice. You have to have, someone already has to be sick to kind of get sucked into this, okay? Remember we talked about egosyntonic versus ego-dystonic? Well, anorexia is a highly egosyntonic disorder. So they don't believe anything's wrong, okay? It's compatible with their own values. They're almost proud of having this diagnosis. Someone with anxiety or depression, there's a lot of shame, even bulimia, that comes with it. I don't want this. This is something that I don't want to live with. With anorexia, it's like they think it's protecting them. It's like this thing that they love, and it's like it helps them feel like they're special. It becomes a part of their identity. And then it's like they think this thing is their eating disorder is protecting them when in fact it's actually killing them. Okay. So we got to be mindful if we're working with teens. And I also want to say eating disorders are beyond tricky because it becomes their whole world and their identity, and abstinence is not possible because like I told you, there's a lot of parallels with an overlap with addictive behaviors, addiction. The difference here is that we all need food to survive. So you have no choice but to learn how to have a healthy relationship with food. We have to eat multiple times a day. Whereas someone with addiction, I'm not saying it's hard to be, because it is, but you could avoid people who engage in that lifestyle. You could have no substances in your house. You could completely get rid of it. Whereas food, we need it to survive. So it becomes like this extra layer. It's complex. It's difficult to beat. So I want you to watch Christina's story. You'll see there's a lot of distortion, isolation, secretive behaviors. There's a shift in her identities and values. She felt special because she was anorexic. So it's about 8 minutes. So go ahead and watch it. And we are going to jump into binge eating disorder. So what classifies a binge from normal overeating? I don't want you to think that if you've ever overate that you have binge eating disorder, because we all have. To classify a binge, the context of behavior must be considered. Binge eating usually consists of highly fatty food, and episodes can contain 4,000 calories or more per binge. Like I said, this is a new DSM-5 diagnosis beginning in the 1990s. Research focused on a group of individuals who experienced marked distress because of binge eating, but do not engage in extreme compensatory behaviors. Therefore, they weren't meeting the diagnosis for bulimia. So this was an area of further study in the DSM-4, and it finally made it to the DSM-5. Exact same thing of bulimia, except for the compensatory behaviors. There's a huge association with distress or functional impairment. So because they are binging on high caloric, high fat, high sugar food, they are putting their health at risk, and there's a lot of feelings of guilt. There's somewhat of a greater likelihood of occurring in males, and at a later age of onset, there's also a greater likelihood of remission and a better response to treatment compared to other eating disorders. So binge eating disorders have higher success rates in treatment compared to anorexia and bulimia. And like I said, with binge eating disorder, there's less of an emphasis on their weight or their shape. Okay. Approximately 20% of individuals in weight control programs suffer from binge eating disorders. So just want to be clear again, just because someone is overweight or obese, struggling with their weight, doesn't mean that they have binge eating disorder. About 20% of people in weight control programs do qualify. Approximately half of the candidates for bariatric surgery suffer from binge eating disorder. However, because there's a psychological component, we don't always see success with bariatric surgery, because the problem really isn't about the food, it's about the psychological piece, okay? I will say that a lot of individuals with binge eating disorder or obesity are sexual abuse survivors. It serves as a form of protection. So I've worked with clients who were overweight, and anytime they start to lose weight or have like the success, they go back into their ways and they gain even more weight. And what happens here is, if the sexual trauma is an abuse, some people use being overweight as a form of protection. So they said that if as soon as I start to lose weight and men start looking at me, I get triggered. So as long as I stay overweight, men won't pay attention to me, and it's not a trigger, okay? So there's a lot of trauma usually with people with binge eating disorder. Like I said, there's a better response to treatment overall than other types of eating disorders. They tend to be older than sufferers of anorexia and bulimia. There's higher rates of psychopathology than non-binge eating obese individuals. About half of the individuals with binge eating disorder try dieting before binging, and half start with binging and then attempt to diet. Those who binge first become more severely affected by binge eating disorder and more likely to have additional disorders. And a lot of times, if someone's binging, an emotional need's not being met, okay? They're compensating for something. So this is on page 280. I'll just go through it quickly. The exact diagnostic criteria for binge eating disorder are, of course, recurrent episodes of binge eating. Binge eating disorders are associated with 3 or more of the following: eating much more than normal, eating until uncomfortably full. So again, they're dismissing their satiation cues, their cues of being full, eating large amounts even when they're not hungry, feeling alone, or eating alone because they're embarrassed how much we're eating. So there's lots of shame, fear of being caught. Secrets keep us sick though, okay? And then there's this huge feeling of disgust or guilt after eating. Again, very much like substance abuse. This will be the last time, never going to do it again. And then when they do it again, it brings even more shame, okay? So this is a story about 7 minutes. I want you to see how he'll go into his story about childhood. And basically what I want you to notice is that his emotional needs weren't being met as a child. And he basically turned to food to meet that emotional need, because we all have that need, okay? I want you to know that binge eating, it's not just someone with a lack of willpower. Binge eating lives in a very shameful place and thrives in secrecy. Binge eating on the couch, at home while watching TV, in the car, hiding food or food wrappers in the house so other families won't see, buying binge foods online to avoid facing grocery store employees or restaurant staffs. These are all examples of eating disorder behavior driven by intense feelings of secrecy and shame, okay? Shame is perhaps one of the most painful and uncomfortable feelings to tolerate. When people are feeling shame, they don't just think I've done something wrong. Shame feels like I am wrong, or I'm unlovable, I'm broken. Shame typically lives inside of someone. It's unseen and invisible, and it makes it very difficult for family and friends to reach out or even know how to help their loved one, okay? So this is a big component of this type of eating disorder. And I also want to talk about boys. I know I use the pronoun her and she in females, and it is true that we see this more in females, but it doesn't mean that males are immune. A lot of times, in fact, males who have eating disorders are misdiagnosed. So maybe they're losing a lot of weight and the doctor might say, oh, they're just depressed, they don't have an appetite. Right now, less than 1% of eating disorder research is done on men. But it's more common than we originally believed. It used to think that this was a female disorder, when it is not. There's a lot of misdiagnosing that takes place. Males are also subjected to powerful media images, just in different ways. Some symptoms overlap, as we see in females, but they tend to have a less preoccupation with food or drive for thinness, and more on muscular development. Young men place an emphasis on being muscular. We also see that sexual orientation can play a role. Gay men are at greater risk for behavioral symptoms of eating disorders compared to heterosexual men. They're more susceptible to experience poor body image and body dissatisfaction, okay? So I really want you to know that it's not a female thing. Men can suffer too. And in fact, there's more pressure because there's like the stigma, oh, only women have, these types of problems, but men can too. Males with eating disorders tend to be older, have greater risk of other psychiatric problems such as depression, anxiety, and substance use, and engage in more suicidal behaviors than females with eating disorders. Males with eating disorders also have a high rate of having a history of being overweight. Men are less likely to engage in typical purging behaviors and are more likely to utilize exercise, so the non-purging type. Finally, because of stigma, males are less likely to seek treatment. When they do, it's often after a long illness, and they may be sicker and more entrenched in their eating disorder, okay? So let's throw some facts and statistics out here. Bulimia. So clear cases of bulimia have been described for thousands of years, but bulimia was recognized. The majority were female. 90 to 95% of individuals with bulimia are women. Makes Some binge eating symptoms are relatively common in men. Male athletes in sports that require weight regulation, such as wrestling, are another large groups of males with eating disorders. So in wrestling, you have to make weight. So sometimes men will revert to extreme measures. The incidence, so the amount among males is increasing about 0.8 to 2.9 in binge eating disorders. 6 to 7% of college women suffer from bulimia at some point. The onset is certainly in adolescence. That's when we're at highest risk. And it tends to be chronic if left untreated. So usually it's not something you could beat by itself. And I also want to note that most of our data that we have, all the research is on women. As far as anorexia, the majority are female and white. From middle to upper class families, usually develops around early adolescence, so around puberty, maybe 11 to 13, and when it hits at that age, there's likely a chronic course, meaning that it doesn't go away easily. Anorexia is much more chronic and resistant to treatment than bulimia. These individuals, again, it's very egocentric and they don't have a rational state of mind. They don't feel like they have a problem. The lifetime prevalence is approximately 1%. We also want to always consider culture. So developing non-Western women after moving to Western countries. So a research finding is that these disorders develop in immigrants who have recently moved to Western countries. Just basically saying that our culture plays a role, the media plays a role. But it's not all culture, as with all disorders. Biological, psychological, and social factors contribute to the development of serious eating disorders. The social dimensions, so remember that anorexia and bulimia are the most culturally specific psychological disorders. What drives so many young people into punishing and life-threatening routine, into semi-starvation or purging? For many, looking good is more important than staying healthy because of all of our media pressure, right? So we have culture factors. So what do our cultures value? Maybe I grew up in a highly perfectionistic family and we placed a lot of emphasis on our outward appearance. Dietary restraints, study of starving individuals become obsessed with food and hoard it. Family influences, high expectations, or competitive environments place someone at higher risk. Someone who has a parent with an eating disorder also models that behavior to their children. And then we have the biological dimensions. So eating disorders can run in families and thus seem to have genetic components. Studies have suggested that relatives of patients with eating disorders are 4 to 5 times more likely than the general population to develop an eating disorder themselves, with the risk for female relatives of patients with anorexia makes the risk higher. And then psychological and behavioral dimensions, so someone born with more of like an anxious temperament is at higher risk. So of course we have to talk about media and cultural considerations because our media, I think we've come a long way, but thinness is linked to success and happiness. Lots of mindsets of once I get to this weight, then I'll be happy. Once I get to this weight, then I'm worthy of love, which is very, very sad because any shape, weight, no matter who you are, where you're at, what you look like, you're always worthy of love, connection, and belonging, okay? There's also a myth that people who are overweight are perceived as lazy or having a lack of willpower, which could be so much more going on, so it really breaks my heart. Again, a lot of people who are obese have a history of sexual or physical trauma. Our culture emphasizes dieting, but diets don't work. If they did, no one would have a weight problem. Obesity wouldn't be a public health crisis if dieting worked, okay? It's a lifestyle thing, and a lot of it's psychological, okay, which is why diets don't work. The standard of ideal body size, so now we have 000 in sizes for adults, and that doesn't seem like an adult size to me. Women are supposed to have curves. Our bodies are meant to carry babies. We all have different body types, but that doesn't make anyone right or wrong. And where our culture shifts, we're frequently changing and difficult to achieve. Sometimes curves are in, like if you look back at Marilyn Monroe, she was considered beautiful, but now she would be considered a plus size model because of basically our perceptions and what we expect. In the 1990s, less curves, more thin. Nowadays, more curves are becoming desirable. So it's kind of like, how do we keep up, right? And we all have our own body style, and sometimes it's just not possible for us to achieve a body type because of the way we're born. So it's like this impossible thing to achieve, and then it's constant feelings of failure, of not being good enough. And this places those of us who are more susceptible of mental health challenges at greater risk of eating disorders. Using dietary supplements can lead to other serious problems such as binge drinking or other drug addictions. And that's whether to control their appetite, so maybe they start using drugs so they don't feel hunger, or further numb out their pain, okay? Too much or too little of anything is never good. Dieting and dietary restraint. So adolescent dieting leads to an 8-time greater risk for development of an eating disorder. It's really concerning when you're hearing children talk about their weight and going on a diet too young. They may be internalized and expressed in children as young as 7 to 10. I have 7-year-olds tell me that they think they're fat, that they see their mommy going on a diet and constantly berating her own body. So that doesn't teach the child to value her body. Kids are already aware of weight standards. Preoccupation with weight and dieting are factors that lead to an eating disorder among vulnerable adolescents. We're seeing eating disorders come on younger and younger, as young as 8 years old. Adolescence is a turbulent time as it is, so they're at incredible risk here. They tend to internalize standards of friendship groups. So a teenager is more likely to diet if her friends are dieting. They're heavily influenced by what their social circles are doing because, again, they're trying to figure out where they belong, who they are, so they're more vulnerable. This may paradoxically cause weight gain, as described in previous slides. This shows how dieting can actually lead to weight gain because of the feelings of deprivation, and adolescents aren't educated on this, and this produces stress and withdrawal symptoms that increase cravings for food. Okay, so again, eating disorders thrive in secrecy and isolation. During periods of restricted food intake, people become preoccupied with food and eating. So the less I allow myself to eat, the more obsessed I am going to be with food, and that's just natural human tendencies, okay? There's a classic study that was done during World War II where volunteers, basically what they were wanting to know was how caloric deprivation, what that did, if anything, to mental health. So the volunteers were placed on strict diets, and the longer the time went, they started thinking, writing, and reading more about food, and they lost interest in everything else. They didn't care about sex. They didn't care about interpersonal relationships. It was all about food. So when we're deprived, we become obsessed, okay? So dieting leads to this, or often leads to this vicious cycle of weight loss and weight gain, which is also known as like yo-yo dieting, okay? Patients with distorted perception of food and eating may restrict child's intake too, whether on purpose or inadvertently. So someone may put a quote unquote chubby toddler on an unnecessary diet, which is never okay. I've worked with eating disorders, and this just gives you an example of how egocentric and complex these disorders are. So I had a teenager who I was working with who was starting to develop an eating disorder, symptoms of an eating disorder behaviors. And it turns out her mom had anorexia, and her mom would actually get competitive with her daughter in their body weight. So the mom had to weigh less than the daughter, couldn't eat more. And so it was just this unhealthy relationship, okay? Families of individuals with anorexia often are high achieving, so there's a lot of perfectionism, straight A's, the best in sports, high achievement. There's concern with external appearance, so there's this high need for approval. They're obsessed, they're rigid, poor adaptability to change. So again, there's lots of parallels with like obsessive compulsive behaviors. And they're overly motivated to maintain harmony, meaning like conflict is a trigger, okay? And we know with any relationship, there's going to be conflict or times of like discomfort. But what happens is they're so threatened by this, it leads to poor communication and denial of the problem. So they don't voice their own needs, their own opinions, or, you know, there's in the family, they don't talk about the hard stuff. So the problem's ignored, okay? Yes, I know my kid has a weird, you know, concerning behaviors, but we're just not going to talk about it. Maybe it'll go away on its own. And that shows the person, or gives kind of like this false sense that like, I don't matter enough, something's wrong with me, but I'm not important to get a help, making them feel like they're all alone in the disorder and like there's no help available, okay? Psychological dimensions, it's like a perfect storm, okay, with eating disorders. There's a low sense of personal control and self-confidence to begin with. So very, very anxious people. And remember when we talked about anxiety, there's this sense that like whatever happens my way, I can't handle it. I don't believe in myself. I don't trust myself. And then they have this perfectionistic attitude. I have to be perfect or else I'm not worthy, which is impossible to maintain, right? And then they start to fixate on their body image and become preoccupied with food. And they have like a low threshold for any type of stress. They have mood intolerance. And all of these symptoms are going to be exacerbated with a starved brain, okay? Because what happens when we're hungry, right? Just anyone without an eating disorder, we get hangry, right? We get irritable, we don't feel good, maybe we fall down. And that just basically exacerbates all the symptoms. So let's talk about treatment, okay? Up until the 1980s, psychological treatments for people with eating disorders were directed at the patient's low self-esteem and difficulty in developing individual identities. Disordered patterns of family interaction and communications were also targeted for treatment. These treatments alone, however, did not have the effectiveness the therapist hoped for. So let's start with drugs. Primarily, these individuals are given antidepressants, but they're generally ineffective for anorexia nervosa, but we see good results with bulimia, particularly the use of Prozac. But anorexia, the reason why we're maybe not seeing good results is there's a lot of resistance to taking it. And that is often due to a fear of the side effects, AKA weight gain. They're worried that their appetite's going to increase and they're going to lose control. Okay, so there's not a lot of medication compliance with those struggling with anorexia. Psychological treatment, so usually cognitive behavioral therapy is utilized. We want to focus on core pathological mechanisms and their distorted body images. Enhanced cognitive behavioral therapy is specifically for eating disorders. It's the gold standard for bulimia nervosa. It's more structured. It focuses more on eating unique symptoms that are associated with eating disorders, and it's the treatment of choice, which is what I want you guys to know. Antidepressants, tricyclics, and SSRIs help reduce frequency of binges and purges, which is a good thing. That's why we see results. We utilize interpersonal psychotherapy, which is focused on relational problems. Lots of times people with eating disorders feel a lack of connection. This is a really good book just for clients or for yourself. self-help techniques can be useful, but someone with a full-blown eating disorder is always going to need, is always usually going to need additional support, usually beyond just one person. When we treat eating disorders, we treat them as a team. So there's a psychiatrist, there's a nurse, you know, we got to keep up on their medical side of things, a therapist. The first and easiest goal of achievement is their health. So we need to always focus on medical stabilization before the psychological piece takes place. Again, we need them to be alive and functioning to start treating the psychological components, okay? Because these individuals have serious complications due to comorbid diagnoses, they're at higher physical and or psychiatric risk for suicide and for medical conditions, okay? Like I said, the problem is not really about the weight and the food, but we have to get them medically healthy. Once we work through the trauma and whatever's kind of underlying these symptoms, those, you know, the food and weight symptoms should start to subside. But we always need to focus on medical stabilization first, and that might start with a hospitalization. Maybe they have to be force fed, which is really, really unfortunate and traumatic. So we always try to use the least invasive interventions as possible, but sometimes it's needed because, again, we need them alive. Weight restoration is the starting place if they're in medical danger, and that's not easy. But just because their weight is restored does not mean that they are cured. Weight restoration is often a difficult task, but is actually probably the easiest part of treatment, and that just shows you how complex these disorders are. Clinicians who treat patients in different settings find that at least 85% will gain weight, but not always sustained. So maybe they gain half a pound a day and then they get in the normal range, and usually there's, just like addiction, relapse isn't uncommon. There are different types of treatment platforms for all eating disorders. They could have an inpatient program, a partial hospitalization program, or intensive outpatient program, just depending on the severity of their diagnosis. And we want to educate them too. We want to educate them on the medical consequences, the role that food is playing in their lives, the role that their weight is playing in their lives, and what often leads to these behaviors. So we have behavioral and cognitive interventions for anorexia. For restricting anorexics, the focus of treatment must shift from their marked anxiety over becoming obese and losing control of eating, as well as their undue emphasis on thinness as a determinant of self-worth, happiness, and success. We want to target food, weight, body image, thought, and emotions. So we want to identify these pieces beyond the food and weight stuff. We want to dig deeper, okay? The only way out is through. And this population's avoiding feeling by focusing on their weight and food, okay? But the only way to heal is to feel, okay? Treatment often involves family. Family-based treatment has been the most successful in treating anorexia because it's deemed to be a family problem, just like substance abuse and alcoholism. We often see someone like an adolescent struggling with anorexia. There's negative and dysfunctional communication in family regarding food and eating. We want to eliminate that. Meals must be more structured and reinforced. We want to hone in on the family's attitudes towards body shape and image distortion. What does the family value? How can we adjust this? Unless the therapist attends to these attitudes, individuals with anorexia are likely to face a lifetime of preoccupation with body and shape, struggling to maintain a marginal weight and social adjustment, and be subject to repeated hospitalization. Anorexia is a tough one to be, and again, relapse in different times of life, like stressful periods, isn't uncommon. So it's more so someone has to live a life in recovery, like someone who maybe has alcoholism, versus being recovered, okay? Preventing eating disorders, we could do a lot. So like in schools or just within homes, We want to promote body acceptance in adolescent girls and boys. It's never too young to start. We want to identify specific targets, early weight concerns. We want to screen for at-risk groups. At-risk groups are like dancers, ballet, sororities, people with a parent who has an eating disorder, competition programs. We want to provide psychoeducation, normal weight limits. Anyone on social media always highlight what reality is. Being thin and being healthy isn't necessarily synonymous. We want to teach our kids that a lot of the things that we see in the media and in magazines are photoshopped. We want to talk about the effects of caloric restriction. Limiting our calories does not make us more healthy. There are scary repercussions of heavy restricting, and there are serious consequences of compensatory behavior. So if we could avoid it and prevent it, it's much easier to treat, okay? Here is a number of resources, some books. This is a Netflix film on Netflix right now. I don't know, it's okay to me. There are some, I think it displays what symptoms look like, but anything that's like a movie doesn't always portray an accurate depiction, but it's interesting. This is a good book if you have someone in your life that you love who struggles with an eating disorder, because it's really difficult. Some people think like, why can't you just eat? It's not that hard, when it is hard. This is a great podcast of, living in recovery. These two are good books. So I encourage you to check these out, not only just for more information, but it's likely that you know someone or have known someone, or maybe you've struggled yourself, okay? They're not easy things to beat. And then 2 more videos I want you to watch. These are really, really, this is a good story. It's an intense story, so take care of yourself, but it shows how easily and how common it is to cross over into different types of eating disorders. So a lot of times someone who's anorexic, just because they gain weight and then they're in a healthy range, a lot of times people think, oh, okay, they're good. But if the psychological components aren't worked through, it's really likely they cross over into a different type of eating disorder over time, like bulimia and or binge eating disorder. Okay, so I want to know your thoughts here. Post them in discussion. Read the chapter, and we will see you in the next lecture.